It's my pleasure to invite my very dear friend but an expert on visual rehabilitation and particularly neuro-ophthalmology, Dr. Varshini. And I think the first three were more about surgery and how you do, but the more important part of how you make good of that surgery in the time to come is now the next two talks. So I would urge you all to pay attention to newer ways of rehabilitating children.
Thank you, Dr. Vaishali. Thank you so much for inviting me to be a part of this IC. And after those wonderful videos, so basically at the end of surgery, we have the eye is healed, the IOL is inside. So my talk is pretty much on taking off after the surgery. So achieving a good visual outcome requires early surgical removal of the cataract, of course, but consistent optical correction of both the aphakia or the large residual errors, because as you said, now we are implanting pretty much 7 months onwards. So there is a large residual error, especially in unilateral cataracts, and then compliance with amblyopia therapy. So refractive correction of aphakia and pseudophakia can happen, as Dr. Vaishali had described, with glasses, with contact lenses, and with secondary IOLs. I won't go into this because this has already been described in detail. But pretty much we all agree that now we have younger and younger children with who are pseudophakic with a large residual refractive error, or aphakic if they are very small eyes who need to be rehabilitated. So spectacles provide satisfactory correction for bilateral aphakia. We give near dominant glasses younger than 3 years of age, and once the child starts reading, shift them to bifocals or progressive glasses. We also need to remember that many of these children have other facial abnormalities as well. They may have low set ears or a flat nasal bridge, because of which the glasses don't fit. Sometimes they're wearing hearing aids as well if they have multiple systemic problems, and they may require modifications of their glasses to provide the refractive correction. So in pseudophakia, primary implantation of IOL in even the youngest children with an undercorrection of 6 to 8 diopters implies that nearly all infants will have an amblyogenic residual hyperopia, especially those who have been operated for a unilateral cataract. As Dr. Vasavada said, a dilated refraction or a repeated EUA is often necessary in these patients. Near dominant glasses are given earlier. We prefer contact lenses in cases of significant anisometropia, and bifocals and progressive lenses are started post 2 to 3 years of age. Contact lenses, a wide variety is available. As we've already seen in our clinical context, the acceptability of contact lenses is a major problem. I generally find that parents who themselves are myopic or have had surgery themselves and are comfortable with contact lenses are much more comfortable with using it for their children as well. Silicone contact lenses combines the best features of hard and soft contact lenses. The power available is from plus 12 to plus 32, but they're expensive, and especially the last 2 pandemic years, there was a major problem with supply, so we always need a backup plan for these patients. So now coming to the actual part of my talk. So amblyopia therapy, children with congenital cataract have a stimulus deprivation amblyopia, which is forms less than 3% of all amblyopia. There are no randomized control trials conducted on the management of this kind of amblyopia. Generally, these patients are excluded as it's considered much more severe and resistant to treatment. Now, if we look historically, patching has a very, very long history. There are some descriptions of patching being even suggested in as far back as 2000 years back. Erasmus Darwin in the 1700s, he's grandfather of Charles Darwin, suggested first fusion exercises for strabismus and for correction of strabismic amblyopia. Pleoptics was devised somewhere in the mid 1940s, and it was considered so difficult to overcome the suppression in these eyes that special vision schools were set up in Germany, where children would be admitted and they would undergo this therapy for weeks to months at a time in the 1950s. So this is just goes to say that mankind generally has been struggling with treatment of amblyopia, with patching being the only long-standing treatment which has stood the test of time over the last 1000 years or so. The gold standard for patching is total occlusion to form in light. The infant aphakia treatment study used 1 hour per day per month of age till 8 months of age, followed by 50% of waking hours. The amblyopia treatment study, however, which did not include stimulus deprivation amblyopia, they have noted that moderate amblyopia, 2 hours of patching plus 1 hour of near work works equally as well as longer hours of patching. In severe amblyopia, 6 hours with 1 hour of near work also is extremely effective. Atropine penalization of the sound eye may be combined with plano lens, especially when the child is hyperopic in the good eye. Um, Generally is used in children who are non-compliant with patching or who have failed several attempts at patching with occlusion. So as mentioned, compliance with patching is the major issue, and it is the major issue in unilateral congenital cataract. The monitored occlusion treatment of amblyopia study has found that the actual amount of patching which happens is less than 50% of the prescribed hours, and there may be a ceiling at somewhere around 4 hours. So you can prescribe 6 hours, you'll still get 4 hours, you can prescribe full time, you'll still get 4 hours. And again, historically, there are reports that they used to glue the occluder to the skin around the eye, and there are even suggestions of suturing the eyelids closed for some children who were extremely non-compliant with patching. But now today, in a more gentle age, it has been suggested that educational intervention, this includes showing videos, counseling, cartoons, rewards, as well as maintaining logbooks as to the duration of patching, are very helpful in increasing the compliance from less than 50% to about 80%. This photograph is of a child with an occlusion dose monitor, which has been used in several studies to monitor the actual hours of patching which is being done. These are thermal sensors which are embedded on the internal and external surface to detect the duration of patching. Liquid crystal glasses, some of you may have some experience with them. They were launched in India as well as a couple of years back, didn't really take off. So they are normal glasses, the refractive correction can be incorporated in them. They're electronic controlled occlusion. So basically there's an intermittent flickering, the patching doesn't happen continuously. The glass turns dark and light on and off, so the child is not even aware that the patching is happening. And it can be titrated, the on-off flicker can be titrated depending on the depth of amblyopia and the age. It's obviously cosmetically much more acceptable than a patch. And studies with, small scale studies have shown that it's comparable to patching in moderate amblyopia. So coming to the newer therapies, these include perceptual therapies, dichotic therapies, and virtual reality based therapies. So perceptual learning is based on the principle that practice makes perfect. So it's a series of tasks training the amblyopic eye to detect certain spatial frequencies, and repetitive performance of the software based visual tasks improves the visual performance by inducing plasticity in the visual system. These tasks include gabor detection, vernier acuity, letter identification and noise, etc. The Revital therapy system is FDA approved, and the company claims a 2.5 line improvement and 100% improvement in contrast. However, the main complaint which patients have, one, it is quite boring and difficult to stick through the entire duration because they're very repetitive tasks, so not suitable for young children. And the outcome measures which the patients achieve don't really transfer to real life. So the patient, theoretically, they do read a line better, but don't really feel that there's any practical difference. So these are Gabor patches. They're basically gray gratings, and these are the kind of tasks which are offered during this, where you identify which is the darker image, which square has the image, which image is shifted, and so on. Coming to dichotic therapy, all the previous therapies which we have described is basically just stimulating the weaker eye. Dichotic therapy basically believes that there are inhibitory signals from the stronger eye which suppress the cortical inputs from the amblyopic eye and prevent binocular cortical function. So you can unlock this latent binocular visual function by presenting independent visual stimuli to each eye, which requires the integration of the two images. So the image which is shown to the amblyopic eye is of higher contrast to compensate for the decreased contrast sensitivity, and gradually this higher contrast is reduced as the vision binocularity and contrast improve. It's definitely fun, shorter duration, and may help in improving compliance. Some movies have also come out in the dichoptic format, so you may just be passively watching a movie with a slightly different stimulus being presented to each eye. So the vision therapy system 4 is the one which we have the longest experience with. It provides dichoptic targets using a LCD stereo TV with liquid crystal shutter goggles. The issue with this is, of course, that it is extremely expensive, especially criticism against the goggles were that they get damaged easily with children and they are difficult to replace. Plus it is an in-office therapy, so again accessibility is a major issue. So dichoptic basically means you're separating the images which are being presented to each eye. Now this has been done, computer-based therapies are available like this, where the dichoptic effect is provided by using red-blue or red-green glasses. So as we saw in this video, the background and certain objects in the background are in one color, blue, for one eye, and the moving targets are of a different color which can be perceived with the other eye, and the task can be completed only if you're using both the eyes together. So we've been using one of these therapies, neuropy, for a while now. I have 20 patients, mean age of about 15.1 years. Even in this, about 40% of patients were lost to follow-up, in the sense the entire therapy, about 40 to 45 minutes a day, lasts for about 5 to 6 months, depending on how regularly they do it. And 40% of patients did not come back after 6 months, so we don't know what the final visual acuity is like. But in those who did follow up, we did find an average of 1.5 line improvement in vision. But again, this group generally tends to be very non-homogeneous, in the sense they may be detecting it at 13 years of age, you're starting glasses for the first time. Some of them are combining patching as well because they want to try everything which they can. So we really don't know if it is the effect of the therapy or not. And virtual reality based vision therapy is aiming to overcome some of these shortcomings. So this is a company called Vivid Vision, again a dichoptic based therapy, where you divide the two eyes. You have one scene for the weak eye and one scene for the strong eye. You increase the signal strength, so a stronger image for the weak eye and a suppressed image for the stronger eye. And gradually these images are equalized as the vision improves in the weaker eye. And this is how it actually works. You wear a virtual reality headset, and it's pretty much like playing a game. Inside the virtual reality headsets, you're provided targets which you have to shoot using both the eyes together, and the background is common between the two eyes. Luminopia 1 is a new therapy which is being launched this year. It has been FDA approved. It's getting a lot of push from prominent pediatric ophthalmologists in the US. Basically how it works is the therapeutic visual stimuli is provided by real-time modification of TV shows. So these may be things like Sesame Street, which the child is already familiar with, and you wear the headgear, the virtual reality headgear, and you can select what shows you want to watch, and you do that for maybe 1 hour a day. This is a recent study which was published by them, where 51 patients, they wore glasses plus 1 hour of Luminopia 1 therapy a day for 6 days a week for 12 weeks. The control group only wore glasses. There was no therapy, no patching. They did say that the visual acuity improves by 1.8 lines compared to only 0.8 lines in the comparison group who are only wearing the glasses. And finally, this is a system, the orthoptic magnocellular stimulator devised by Dr. Santan Gopal. This works on the principle that patching works from a bottoms up principle, which means that the eye goes and stimulates the brain, whereas he feels that stimulation of the magnocellular cells and the overt and covert attention mechanism increases the top-down impulses from the brain, from the posterior parietal cortex, which increases the lateral occipital activity. He's reporting extremely good results with this therapy, and I know a lot of these devices are now being used all across India. So I think we'll have more data maybe in 6 months or so to see how effective it is for different kinds of amblyopia. And finally, I want to conclude by saying that we still need to look at the child as a whole and not just the eye, not just the amblyopia. Many of them have multiple disabilities which may include walking, which may include hand-eye coordination, several learning disabilities as well. So rehabilitation involves medical, social, educational and vocational measures for training the child to the highest possible level of functional ability. Thank you so much.
Thank you so much. And thank you for that excellent presentation. I would now request Dr. Meenakshi to set up her talk. And really, I'm very happy to have her in my course for the first time. Last year, madam, last time she couldn't attend. And she has been a teacher of teachers at Shankar Nitralaya for several years, and I indirectly am her student. My husband he claims being one of her pet students, which I'm sure is not true, but but while madam is setting up and talking to us about the paradigms for squint, Varshini, I have a question. I mean, I'm more of a cataract surgeon and a pediatric cataract surgeon. I'm not very good at these newer modalities for visual rehab. Now, a lot of parents come and ask us that, is there any mobile game? Is there something we can do? So, what would be those one or two things which are maybe a cell phone game, or other than patching, what are the top one or two things which you would recommend in these?
Or in other words, commonly they ask, my child is looking mobile, please tell him not to use it, kind of thing. So what's your advice? Now tell us. Is it good or bad?
So,
Because we are loaded with every other patient or mother would say, and they want us, they would prompt us before.
You tell them, you tell them.
Please tell them not to use the mobile.
Yes, I think that is true.
So what we usually advise is mobile phones definitely, I mean, playing games definitely helps them in focusing. So we do say that while patching, if you're doing 6 hours of patching, obviously they're not playing the mobile the entire time, but if they patch properly, you can let them play games for the last 1 hour of patching. So which is a reward at the end of proper patching. So it's something which the child looks forward to as well. And to answer Dr. Vaishali's question, there are some games which have come out with a dichotic variation. The red blue glasses which I mentioned, they're very cheap. They are available on Amazon for about 400-500 rupees. And these games, especially there's one very popular one called Tetris, which is available on the iPad, and I think there's an Android version as well. So it's called Lazy Eye Tetris. And it's played with these blue-green. So again, some of the blocks, it's a falling block game, basically. And so some of the blocks are red and some of them are blue. And that is what I suggest, like when they ask, is there something extra which we can do? Because it's very simple to do. You just download the game. It's free to download. The glasses are available off Amazon to order. So I tell them that they can do that along with the patching. But generally, I'm still...
You're not answering my question. If they are not patching and if the mother tells you, please tell my child not to, how do you handle that? It's so common. I want to learn from you, the mother.
So the normal children, I tell them they're not touching the phone, that their phone needs to be
Why
kept
not? You said it's
kept away. No, for the children who are patching, yes, I do advise that
what
they...
is bad about using
So we are having a lot of issues with mobile phone usage. So that is not entirely related to amblyopia, but some forms of squint, especially accommodative esotropias. I think Dr. Leela Mohan will agree with me. The incidence of strabismus has...
I think she wants to say that's the other instruction course. the one about excessive
So that has
smartphone use.
increased massively. So we definitely discourage.